are in listen-only mode.
Hello everyone and welcome. I'm John Britt, your moderator. Today's webinar, Influencing Local Policy, Public Health Policy, is presented to you by the Washington State Public Health Association. It's your statewide professional association. We're dedicated to public health leadership, professional development, and advocacy. We really appreciate your interest and your attendance today, and we hope that if you've not already done so, you will join or renew your membership in WSPHA, both to protect and enhance the health of Washington State and also to support the public health profession. We're going to get started in just a moment, but first I'm going to ask Betsy to orient us to the go-to software so that you can participate effectively in today's webinar. Betsy?
Thank you for joining us today. Before we get started, we'll just go over a couple of technical issues. First, for the best audio and visual quality, please exit from any applications that communicate across your network, because that can delay advancement of the presentation on your side. Next slide, please. Secondly, this is the control panel. You're generally connect to the webinar initially using your microphone and speakers. For optimal quality using your microphone and speakers, it is best to use a USB headset. If you do encounter audio issues during the presentation, you can switch to the telephone by just clicking on the Use Telephone and following the directions that are there. We will be taking questions today through the questions box in the control panel. So if you submit them, we will monitor them and pose them to the presenters. And then finally, the presentation slides and recording will be available after the webinar. I should be able to get them up by the end of the week. If you have any other questions about what's going on, please just submit them through the questions box to me during the presentation. Thank you.
So this is John again. The policy and systems buzz has been in the air for several years now and in public health, but it's still a relatively recent emphasis, and all of us are eager to learn from those who are making some headway. Today we are privileged to hear about two case studies in local policy making, one from Pierce County and the other from Clark. We know that many of you in the audience are also involved in efforts to influence policy making, and we look forward to your questions and comments in the chat box. Our first presenter is a former colleague and friend of mine, Kirsten Franzen. Kirsten is a program coordinator at Tacoma-Pierce County Health Department, where she leads the tobacco prevention and control and physical activity and nutrition teams there. Kirsten has been involved in several local policy development initiatives. Today, she's going to tell us a story about a recent effort related to tobacco. Kirsten?
Good afternoon, everyone, and thank you for the introduction, John. I appreciate that, and I appreciate the opportunity to talk with you all about a local policy development effort that I've been involved with, or I was involved with last year at the Tacoma-Pierce County Health Department. And as John mentioned, I do have experience in policy development, but I'm certainly not an expert, nor do I claim to be. This was very much what I will present today was very much a learning experience for me, and I'm really happy to share what I learned from that experience. So Betsy, if you could turn to the first slide, please. So before we start, I wanted to provide a little bit of context about our health department. And the health department was the lead agency for passing a policy that I will describe momentarily. But wanted to share a little bit about our mission and vision and our capacity to do policy work. So the mission of our health department is healthy people and healthy communities. Our vision is to safeguard and enhance the health of communities within Pierce County. We have a pretty strong emphasis in our health department on prevention, and we have for several years. And that has meant that we have significant capacity in prevention and staffing. We've lost a lot of capacity over the years due to budget cuts, but we still have a strong history of chronic disease prevention and tobacco prevention. We have several goals for tobacco prevention at our health department. One is to reduce youth and adult tobacco rates. Another is to reduce alternative tobacco products, such as the one that I'll be talking about today. And then also we want to reduce exposure to secondhand smoke. And as mentioned previously, we are very fortunate. We are the second largest health department in Washington State, and we're very fortunate to have a good amount of funding going towards prevention and tobacco prevention. On our staff, we have about 7 full-time staff working on tobacco issues and a budget of approximately $1 million annually. So looking at the next slide, I wanted to provide a little bit of context with regards to our environment here in Pierce County. As mentioned previously, we're the second largest county in Washington State. We have about an 800,000 population. And as also mentioned, we have a very high level of chronic disease. We have one of the highest rates of heart disease and diabetes in the state. And again, we put a lot of focus on reduction of chronic disease, and we do that through tobacco and also physical activity and nutrition. We've been very successful, I feel, with our tobacco efforts, our tobacco prevention efforts in Pierce County. And the rates of our tobacco use, adult smoking rates and youth smoking rates have decreased pretty significantly over the last decade, and they're very similar to the Washington State averages. So for instance, we've seen a drop in 6 percentage points in adult smoking over the last decade, from about 22% to 16%, again, in the last 10 years or so. So we've made some pretty significant progress, and we'd like to continue that progress. We've had a lot of work that we've done over the last 10 years. One of the things that we've done that maybe you've heard about is we've taken pretty aggressive stances on some issues surrounding tobacco, and one of the most well-known efforts is us taking a stance against kind of the smoking in public places issue. And back in 2003, our health department was one of the first health departments, and was the first health department in Washington State to develop a local policy surrounding smoking in public places. And while it was adopted by our board, ultimately it was overturned in federal court, but it did serve as a model policy for the 2005 Washington State's smoking in public places law. And this kind of helped set a precedent for us in terms of our aggressiveness and risk kind of non-adverse stance. We have leadership here at the health department that's pretty aggressive, and we were fortunate to have a leader who left the department a few years ago, but replaced by another leader by the name of Dr. Anthony Chen, who is fairly aggressive with regards to these issues of prevention and wanting to put us in a good position in terms of aggressive policies to help lessen chronic disease. We, in Pierce County, we have quite a bit of diversity in terms of our political climate. Tacoma is our largest city, and it represents about 1/4 of our population here, so about 200,000. And for the most part, Tacoma is a pretty progressive and liberal city. The rest of Pierce County tends to be more conservative, and so that creates somewhat of an interesting dynamic in terms of policy development. Our health department and our staff here in tobacco prevention have a pretty strong history of doing policy systems and environmental change work, and so we're fortunate to have had the opportunity to do this work in the past, and so that helps kind of set the stage for this regulation that I'll be speaking about today that we passed. If we can move on to the next slide. So what I'd like to do today is to share a story, and I'm going to jump ahead and tell you the end of the story. And after that, I'm going to tell you the pieces, how the story worked from beginning to end. And the end of the story is that on June 1st, 2011, this was last year, our health department, in conjunction with the Board of Health, passed a policy that restricted the sale, the use, and the availability of electronic smoking devices. And when I say electronic smoking devices, I'm speaking specifically of e-cigarettes, but also of other products that are available or may become available, such as cigarellos, electronic pipes or hookahs if we have those, and other unregulated nicotine products. And so other products might be products such as bottled water products containing nicotine or nicotine-containing lollipops. And we passed this policy, and this policy also prohibits the sale of these electronic smoking devices and smoking or nicotine-containing products to minors. So those under 18 are no longer able to purchase these products in Pierce County. This policy that we passed also restricts places where these devices can be used, and we're speaking specifically of the electronic smoking devices, so electronic cigarettes or e-cigarettes. So what we've done is we are not allowing smoking of these products in public places where minors are lawfully allowed. So anywhere that kids are, we're restricting their use by adults and youth in those places. So places that would be exempt to this law include places such as taverns, where only adults can be. We also have a component in this policy that basically states that these products cannot be given out free or low cost. And the exception is that they can be given out for free or low cost at specific retail establishments that exclusively sell or promote e-cigarettes and related products. And then lastly, this policy allows for enforcement. It gives the health department authority for us to enforce businesses who are selling to minors. And it's very similar to the enforcement regulations that we have for regular cigarette products. Okay, so if we can move on to the next slide, I'd like to talk a little bit about our Board of Health and provide you with a bit of a scan of who they are because they were very instrumental in terms of passing this particular policy. So our Board of Health has 8 regular members and 4 alternate members. These are appointed positions, and they govern all of Pierce County. And the members are, we have 3 members from the Pierce County Council. We have our Pierce County Executive. We have 1 member of our Tacoma City Council, the Mayor of Tacoma. We have 1 member and an alternative member from the Pierce County Cities and Towns Association, which are elected officials that represent cities and towns. And this would be a member outside of the city of Tacoma. And we have 1 at-large position, and this is to be filled by a position or by a physician who is recommended by our Pierce County Medical Society. So that's a little bit of a scan of our Board of Health. We can move on to the next slide. So now I'm going to take you through the story itself. And to tell the story, I'm going to use a conceptual framework. And there's many different types of conceptual frameworks for policy development, but this one that you're looking at is a framework that many of you are probably familiar with. It was developed by Vic Coleman when he was a senior policy advisor at the Department of Health, and this was developed back in 2006. And what I'll do for the rest of this presentation is take you through each of these steps and talk with you about how our story is relevant to each of these steps that we've provided out here. Okay. So moving on to the next page. While this story is not specific to the issue of e-cigarettes, I'm sure you're not all tobacco, involved in tobacco prevention efforts. This story really is one that hopefully will be useful to those of you working outside of tobacco as well. But when I did a survey to get a sense as to how many potential participants knew about e-cigarettes, it seemed as if there were several of you that did not have much familiarity with e-cigarettes. So I'm going to take a few moments to talk with you about this particular product and why it's an issue for us. So e-cigarettes are products that are designed to deliver nicotine and other substances to the person who's smoking them, but it's in the form of a vapor rather than smoke. And they have a rechargeable battery-operated heating element, and it's a replaceable cartridge that can, as I mentioned, contain nicotine and other chemicals. And the vapor is inhaled by the user. Many times these products are designed to look like traditional cigarettes or cigars or pipes, but they can also resemble everyday items such as pens and even USB memory sticks for people who wish to use the product without others noticing. So this is often promoted by the manufacturers and also by the supporters of electronic cigarettes as a cessation aid, so something that can basically help them stop smoking. And their availability and their use in Pierce County is really not well documented, nor was it last year when we began the development of this policy. But we did know that they were becoming more popular. We were starting to see them being sold in smaller businesses and mom and pop types of retail stores, as well as chain stores such as 7-Elevens. We were seeing them being sold in kiosks at the mall. And we wanted to really get ahead of the issue before it became more widespread. Okay, so turning on to the next page, next slide. So going back to the policy development framework that I shared earlier, when looking at the first component of the policy development process, the partnerships and collaborations is the first step. And for us, and I think if not most or all health departments, developing strong partnerships and collaborations and identifying health champions out in the community is part of our ongoing work. So it's not necessarily part of a policy development process, but it's just a necessary and an important piece of our work. And what it does is it creates a necessary foundation for a lot of our work in our community, but it's very, very critical, and it has been critical for us in developing policies at the local level. If it weren't for the strong partnerships and collaborations that we have with individuals and organizations, we probably would not have been able to develop a policy or a very strong policy for e-cigarettes and other nicotine-containing products. So those of you that are paying close attention, you may wonder why, if we're kind of tobacco prevention, why we're going after e-cigarettes. And where we're concerned at a health department is that that these e-cigarettes may become a kind of a gateway for cigarette use. We also have some other health concerns associated with them, but we definitely want to kind of stop the availability, stop the use before it becomes an issue. We've been really fortunate to have very strong partners both locally in the form of organizational champions through our coalitions. We're very fortunate in Pierce County to have some really great coalitions. We have a coalition known as TAP, the Tobacco-Free Alliance of Pierce County, and they've been very instrumental in working in developing and supporting local policy efforts. We also have strong partners nationally that we've been able to develop through some larger national grants that we have. And we've also been really fortunate to develop relationships with other tobacco managers at other local health jurisdictions and teams through facilitation of efforts by the Department of Health. We also developed within our own internal organization some partnerships and a team that was very instrumental in helping us move this policy forward. In development of this policy, we had an ongoing team that met, and the team consisted of the division director, assistant division director. Our legal counsel was involved every step of the way. communications manager. And we were also fortunate to have a resident intern from Madigan who was a doc who was able to provide a very different perspective on the issue as we went through this process. Okay, moving on to the next slide. So identification of the issue and identifying the issue. And as I mentioned briefly, we had some concerns about e-cigarettes. These products popped up on the market. They are not regulated by any federal agency. They're not regulated by the FDA. The FDA has conducted some research on the e-cigarettes and found that there are varying degrees of nicotine in them, and it's not consistent in terms of ingredients that are found in these particular products. And some of the results found that they have products, very dangerous products, for instance, diethylene glycol, which is a chemical used in antifreeze. And we also know that nicotine is very harmful and can be harmful to humans and has effects on the central nervous system. So we didn't want to introduce potentially harmful products into our county, and especially with our youth. And as mentioned previously, you know, these e-cigarettes can look like cigarettes, and we were very concerned with the potential that when folks and youth saw people smoking e-cigarettes, whether that would increase the likelihood or the social acceptability of these products, and even thinking that they were regular cigarettes. So we were fearful that maybe our smoking rates would go up again. Additionally, if youth are trying these e-cigarettes and these new alternative products, if they get hooked on the nicotine, we felt that they may more easily go to cigarettes, regular cigarettes. Okay. Moving on to the next slide. So determining policy options, this is where our work started to get really, really exciting. You know, each policy development process is very different, and for us, we actually spent a lot of time on looking at our policy options. For this particular policy, our Director of Health was interested in pursuing a policy on e-cigarettes. And it was one of the driving factors in why we decided to move forward with this policy. It certainly was not kind of low-hanging fruit in terms of something that was drastically needed at the county, but we also are restricted in terms of what we can do in the local environment because of preemption laws. But we felt that this would be something that we could nip in the bud early and focus our efforts on. We spent a lot of time doing research, and some of the research that we did pretty early on is we contacted our peers within Washington State. We contacted DOH to get information about e-cigarettes. I'd like to call out Seattle-King County Public Health. They are just great leaders in tobacco prevention work, and they were able to work with us and sharing with us their successes and challenges in developing an e-cigarette policy. And we basically used their policy as a template for ours, and it was wonderful that they were willing to share that with us. And so our policies really do resemble each other, but we do have some tweaks in them, in ours. We were able to contact the FDA and talk with them about their research. We obviously did our research on the web to get more knowledge about the issue. We contacted our national partners to find out what they were doing. At the time, there were not a lot of policies on e-cigarettes, and so we felt in a way that we were flying somewhat solo. In developing, in doing our planning and kind of developing our policy options, we also really wanted to look at our stakeholders. We wanted to look at our supporters and opposition and really look at the social climate in our county. And the supporters, we knew who those supporters were because we did reach out to our partners and our collaborators, and we educated them on what we were going to be doing and asked for their support and let them know how they could become involved. But we also learned pretty early on who our opposition was. And in this particular case, I think this is one thing that makes our story pretty interesting is that there is one e-cigarette shop that exclusively sells e-cigarettes, and it's in Lakewood in Pierce County. And I'll be telling you a little bit about their campaign, which was very aggressive and a coordinated effort to push back on the policy that we were bringing forward. Okay, turning to the next page. So looking at the social climate, again, the most interesting piece of our work, and we know that passing a policy is not always clean, meaning that we don't always have the agreement and the support of stakeholders in the community. But based on King County's experience, their development of their e-cigarette policy was pretty easy. It was pretty clean. There was not a lot of backlash by the community, and we kind of expected the same thing. And we were very surprised to find out early on that there were some folks that opposed our proposed policy. So when we talk about our Board of Health, and when I mentioned them early on, we have some very strong members of our Board of Health that have supported our issues and our policies in the past, and they're very aggressive and very progressive in terms of supporting prevention. But we also have members on our Board of Health who tend to make a kind of a more traditional stance on issues. And for this particular policy, where we heard from the Board of Health, their concerns is that there was not a lot of evidence to show that e-cigarettes were harmful. And in fact, they were showing concerns. Our Board of Health members started to show concerns when we met with them in a study session that e-cigarettes could actually be beneficial for the community because they could be used as a cessation aid and thus reduce regular smoking of cigarettes. So we realized that we had an issue with regards to pushback from the community at a Board of Health session. And we presented this information on the policy and where we were thinking that we wanted to go. And we got feedback from the Board of Health to assess what their thoughts were. And one particular board member who was very vocal during the entire policy process shared with us that there was this business within his jurisdiction of Lakewood, and there was this business owner who he had been talking with and to try to get some more information about e-cigarettes. And he was invited and accepted invitations to go out with her to bars and taverns where she would introduce these e-cigarettes to folks who are using them instead of cigarettes. And she had this Board of Health member talking with customers of hers. And this Board of Health member was particularly interested and swayed with the possibility that perhaps e-cigarettes were a good thing. And so at the board meeting, I'd just like to share some comments that were made. This particular board member suggested that the health department could work with this one business to have us collect data, and that we could go through a comprehensive evaluation to determine whether these were safe and effective. And of course, we did not have the capacity to do that. One of our board members said that they would like more data on the effectiveness of e-cigarettes to use for cessation purposes. One board member told us that they wanted more information before we make a conclusion or develop a policy on e-cigarettes. One board member suggested that we, health department staff, go and meet with this particular business and business owner to learn more about the product. One board member suggested that health department should have nothing to do with supporting nicotine or tobacco. E-cigarettes have nicotine in them, and they want to see data before any action is taken. However, he didn't want to be in a position where we find that e-cigarettes will be harmful and undo all the hard work that we've done to prevent tobacco use in Pierce County. And then another board member stated that we need to use data to inform our plan. We shouldn't use anecdotal information and emotion. If we don't have data to show effectiveness, then we shouldn't be doing it. And that came from a physician who's on our board. So we knew from the start that we were going to have a more difficult time moving through this process, because we had some significant doubts by Board of Health members. We had some community members that were starting to campaign against the idea of a policy that would restrict the use and sale of e-cigarettes. And we engaged in a process to solicit more input from the community. And the processes that we use to submit or to gain more information from the community was fairly extensive. I think traditionally we are required through our Board of Health to have a public input process through a public hearing. That's usually the extent of what we are required to do. However, the Board of Health did express to us that they wanted more opportunity for the public to comment. And so we organized a public hearing. We encouraged the community to come and provide testimony at Board of Health meetings. We provided a venue for folks to provide their opinion on the website and in paper. And so we were very aggressive in terms of soliciting public input. What we found out pretty early on is that this particular business owner who sold e-cigarettes was very savvy, and she did a very fabulous job of rallying the troops and developing a coordinated approach with supporters of e-cigarettes to come and provide testimony and share their thoughts. She learned pretty early on how to get the ear of Board of Health members, and it was not uncommon for us to get letters that were addressed to the Board of Health members that stated their concern about passing a policy that restricted the sale and use of e-cigarettes. So this was an issue that we were dealing with throughout the entire policy process, is to how to kind of look at the pulse of the community, how to develop our strategy based on what was happening in the external world with regards to our opposition. So if we were to look at the next page, I have some pictures here. The picture on the top left is a picture from one of our public hearings, and as you can see here, we have a lot of people, more than what we usually have at a public hearing. And most of the folks in this room are actually the folks that opposed this proposed policy. On the left-hand side is the woman who is the owner of this e-cigarette shop in Lakewood called the Vaporium. And on the right-hand side is the owner again with some supporters of e-cigarettes. And And I took these pictures from a Tacoma News Tribune, which is our local paper. This was actually, she got this story into the local paper, so she pitched the story, and they wrote about it, and it really was supporting her cause. If you look at the next page, I put this on here. This was a clip from the Tacoma News Tribune website, and this was a poll that they put on there and attached to one of their articles on our proposed e-cigarette regulations. And it gave us a sense as to how to direct our efforts. So as you can see right here, most of the responders or respondents felt that they did not like the idea of supporting a policy because of the issue of government overregulation in nanny state. So again, just to illustrate to you that we were fighting pretty hard against what the public wanted, and even what we're hearing from our Board of Health. Okay, moving on to the next slide. So we knew that in order for us to pass a policy that was strong, we really needed to have a very, very strong and coordinated effort here at the Health Department, and also with our supporters in the community. And so we took a lot of time to develop a plan, a very detailed work plan that outlined roles and responsibilities of the various team members involved and timeline. And we met on a pretty regular basis, on a weekly basis, to go over our work plan and to adjust it accordingly based on what we were hearing out in the community and based on what we were hearing from Board of Health members. One of the really important pieces here is that we had our communication manager involved, and she was very instrumental in helping us with our communication strategies. She developed a communication plan, and she was very instrumental in helping to publish notices, issuing press releases, getting information up on the websites, responding to the media, pitching stories to the media, updating stakeholders on policy changes. And she was also very, very good and very proactive in kind of looking at the social climate. And so she used technology such as Twitter and Facebook to kind of keep her pulse on what folks were saying. When articles came out about the issue in our county, we would very closely look at the blogs and the comments that folks had written so that we could use that to inform our strategy. We also recognized as we were moving through this policy development that while we had some very solid partners in place, we really did need to recruit some others. And pretty early on in the media, this one particular board member who I mentioned previously, who was very much against this policy, was really out there in the papers, not speaking on behalf of our policy. And so our communications manager really helped to identify somebody on our board who could speak in favor of that policy. And so she was constantly working to think about how we could get a step ahead. In terms of writing the policy itself, as I mentioned, we were very thankful to have a fabulous policy that was developed that was on e-cigarettes from King County. And so we had staff that worked exclusively on writing up a policy. We were continually changing that policy based on what we were hearing and what the pulse of the Board of Health members were and what we were hearing from the community. For those of you that are interested in receiving a copy of our work plan or our communication plan, I'm very happy to send you a copy of that. So the last slide, you'll see my contact information, and feel free to contact me and I can send you some more information. So what we ended up doing, so getting to the end of the story, is we developed a plan, and the plan and the policy that we ultimately passed was not as strong as the one that we started with. So the policy that we started with was watered down due to the opposition that we faced. And there were a lot of behind closed door meetings to develop a policy that would be acceptable to all board members. What we did not want to happen was to create kind of any conflict or animosity and put anyone in a bad light. We wanted to save face of board members, and so we worked behind closed doors with one particular board member to help us develop a policy that we felt would really be supported by all board members. And so ultimately, that's what we did. The night that this policy was passed, it was passed unanimously. But each board member did provide their comments on the policy, and what we continually heard was, "I'm supporting the policy, but I don't agree with it necessarily, but I'm doing this because of compromise and a desire to satisfy kind of an agreement by all parties, by all Board of Health members." And it was wonderful that they were able to reach that compromise. And I think all in all, we were very happy with the policy and the outcome. And we are moving forward now with implementation. For those that are interested in seeing the policy itself, you can just Google e-cigarette policy regulation for Tacoma-Pierce County Health Department, and that should pop up. If you're unable to find it, again, feel free to contact me and I can send you a copy. So the next slide, implementation and adaptation. One of the things that we all know in policy development is that policy development does not stop with the adoption of a policy, that implementation is the critical piece. We don't want a policy to just sit on the shelf. However, there are critical pieces to implementation that are necessary to have in place in order to move forward with the policy. There were some things that we could do that were very easy in terms of implementation, and some of those things were things like putting out the press release to the media, basically sharing that we had passed a policy. We had sent letters to all retailers letting them know about the policy and enforcement activities. We're really struggling, however, with how to handle compliance and enforcement. As part of the policy, we did give ourselves local authority to enforce sales, but we have not been doing that very actively. And the reason being is that there is a cost associated with enforcement. And we do have enforcement activities here at the Health Department, but our enforcement activities for sales of cigarettes to minors have decreased significantly due to budget issues. And so currently we're not doing enforcement of e-cigarettes in our local establishments, but that's something that we're hoping to do in the future as our capacity increases. One of the things that we learned is that implementation of efforts needs to start as soon as possible. I think one of the mistakes that we made was that we waited until we passed the policy to develop our implementation plan, and it should have been something that we had developed earlier on. Implementation can take a long time, and ideally we should have had that implementation plan in place so when that policy was passed we could have started those efforts right away. And so the last slide, evaluation and analysis. Because of the issue and it not being a very large issue in terms of impact to the community, it was more emerging. We decided to not put a lot of time and effort into the evaluation. And but what we did agree to do with the Board of Health is that we agreed to revisit the issue, and that if any new information or data become available on e-cigarettes regarding safety or its use as a cessation aid, that we would come back a year later and, if necessary, modify the policy. So we are in the process right now of looking at the data, seeing if there's any new data, and we will be presenting that to our Board of Health. So in ending, I believe I covered some of the lessons that we learned, and just to recap is, I think for us, we learned that we always have to anticipate opposition and plan accordingly, even when we think that it may be a topic that is not particularly controversial, that we need to anticipate that it may be controversial. And additionally, it's really important to invest in collaborations and partnerships with the community, even if your budget and your resources restrict you from doing that. And again, we would not have been able to pass a policy without them. They were our champions, our supporters, really came out to the Board of Health. They sent letters to the Board of Health. They came out and provided testimony. And they provided that really necessary voice for why we should move forward with passing this policy. If we didn't have them, then I believe that we would not have been able to pass this policy through. Another lesson learned is really using technology to learn about the opposition strategy. So stay 2 steps ahead. Use social media in your favor, so that you can learn what they're thinking, what their strategy is, and so that you can be ahead. And to continually assess the social and political climate and be flexible as you're moving through this policy development. So I do have my contact information on the last slide. So if you have any questions, I'd be happy to answer them. And I'd be happy to send you any materials that I referenced in my presentation. Thank you.
Thank you so much, Kirsten. Betsy, do you have any questions in the chat box?
We do have a couple comments in the chat box and one question. The first question, Kirsten, came from, I believe it was your second slide, and it was asking if the 16% is the 16% current use.
Excuse me?
Is the 16% current 30-day use? It was in regards to one of the statistics on your.
Yes, it's 30-day use for adults.
And then another comment came in saying that e-cigarettes are promoted as cessation aids, but they are not allowed to do this. If that is being done, it should be reported to the FDA, which you may have commented on already.
We actually were aware of that, and it was not something that we chose to focus on during the process itself. I think, you know, the process of developing this policy, we had a goal date of when we were going to pass this policy. It was only a few months. We did definitely notice on websites that they were promoting it as a cessation aid, and kind of put that in our back pocket for use later, but that was not something that we tried to tackle within those 3 months.
If anyone else has any questions for Kirsten, could you please submit them now?
Yeah, my suggestion, Betsy, is for people to go ahead and put those questions in the chat box. And and maybe we can, if there's anything that we can, when we do the recording, we can add the answers to those. In the interest of time, for our next speaker, I feel that we should go ahead and move forward so that Brendan can also have a chance to tell his story. So thank you so much, Kirsten. Appreciate it.
Thank you.
Our next presenter is Brendan Haggerty, who is an urban planner, who is also a program coordinator at Clark County Health Department. And Brendan is going to share with us his experience in leading a very different kind of local policy-making effort, one that took advantage of the county comprehensive growth management planning process. So, Brendan, thank you so much for joining us today to share your story.
Thanks for that introduction, John. It's a pleasure. So we can go to the next slide here. So I'm going to just, as an overview of what I'll talk about today, I'm going to talk a little bit about how planning and public health have a history together and how they're coming back together now to combat chronic disease. I'll talk about why a comprehensive plan is an important leverage point for counties, especially in Washington State, and then narrate how we approached that in Clark County, addressing health through the county's comprehensive plan, and then finish up with a few points that that you might want to know and that you might be able to use. So if we go to the next slide. So from my perspective, the disciplines of planning and public health have been on this trajectory where they were kind of born together and then grew apart and then have come back together. And if you think about how each discipline was born or had its origins, there was a lot of excitement around both at the same time for a lot of the same reasons. So going back to the cholera epidemic in London, some of the solutions to that were infrastructure projects like clean water and sewage. Moving along, we find more and more examples, and I want to talk about what we accomplished together, the next slide, up until this point that we diverged, and then just talk about the potential that we have going forward. So on the next slide, you'll see a graph, and I borrowed this from New York City because I think it's a great illustration of infectious versus chronic disease deaths in New York City from 1880 to 2005. And this is probably something that's familiar to everyone on this call, is that we've reversed the dominance of infectious disease over chronic disease, and now it's chronic diseases that are our top killers. But what's interesting that goes along with this trend is the advances in urban planning that came along at the same time. So between 1880 and 1940, when we saw that big flip, we got zoning. We got in New York City, we got zoning, Central Park, the Department of Sanitation, subways, housing tenements began to be regulated. And so through all of those things, through those infrastructure and policy changes to the built environment, we helped make this reversal and basically conquer infectious diseases to a large extent. And that was all before the discovery of most antibiotics. So public health and planning really accomplished quite a lot up to that point where we kind of started diverging. In the next slide, we'll return to this path, and you can see, so after that we diverged and didn't quite communicate as well as we once did. And we started using zoning less for things like making sure that residences were located far away from polluting factories, and more for things like protecting property values, or even making sure that certain kinds of people couldn't purchase homes in certain neighborhoods. And that had a lot of negative effects, both socially and on public health. And we began to notice those, and now these two disciplines are coming back together, and they're ready to be integrated again. And across the country, we're seeing more and more examples of this. And we, in Clark County, we hope to provide some lessons from our experience, which has been to address health through the comprehensive plan. On the next slide, you'll see a diagram of why a comprehensive plan is an appropriate intervention point. In the state of Washington, we have the Growth Management Act, which is actually pretty unique among states. But in Washington, populated counties are required to plan. So the intent of that is to make sure that, for example, when we build a new subdivision or neighborhood, that we have a lot of the infrastructure in place so that that growth can happen without some of the growing pains that we've probably all experienced at some point or another, whether it's an overcrowded school or a congested roadway, or even not having enough water, clean water, and sewage treatment capacity. The way that the Growth Management Act gets implemented is through a comprehensive plan, and in turn, that comprehensive plan gets implemented through zoning. So along this chain, the intervention becomes more and more specific, where at the point of zoning, you're looking at a specific parcel of land and saying, this is how this land is allowed to be used. And that has all kinds of implications for public health. And you can do a lot just by looking at that sort of zoning level. You know, that's stuff like, gosh, it would be great if we could have a grocery store in this neighborhood, or it would be really helpful if we could have sidewalks and crosswalks on this street. But to sort of put in motion a broader change and set of changes, the comprehensive plan is the sort of highest level of policy change for land use and transportation planning at the county level. So the comprehensive plan is sort of our most upstream venue for affecting the built environment as it relates to health. And that's why we chose to develop a health element for the comprehensive plan. And that was really driven by a group of community stakeholders in Clark County called the Public Health Advisory Council, and they requested that the Board of Health charge Clark County Public Health with developing a health element for the next update of the comprehensive plan. Now, most counties have an existing comprehensive plan, and so it's a matter of integrating new ideas into an existing document to a large extent. So on the next slide, you'll see the idea that we started with. This simple idea. Cities impact health. But it's a very large and complex pathway from the way that a land use becomes determined by a planning commission, for example, to how that can affect physical activity or access to healthy food. And so we needed to break this down into more manageable chunks that we could really trace that pathway from the built environment to a health outcome. And so we identified 8 different topic areas. You'll see that on the next slide. And they ranged from housing to other topics that are less traditional in land use planning, like food access. And so as we go around this circle looking at housing, there are some clear health impacts, right? Especially when you put it in terms of affordability. When housing is unaffordable, families are forced to make trade-offs that can negatively impact health. Where transportation is concerned, the ability to build in active transportation into our daily routines really provides an opportunity for physical activity in everyday life, and that's not always accounted for in comprehensive plans or in transportation plans. Access to healthy foods, we know, can influence diet, and that that's something that is rarely discussed in conventional planning documents. Safety and social connections gets some discussion in planning documents, but we know that especially safety from crime and safety from traffic are things that can mitigate people's ability to access some of the other health supporting resources in their neighborhood, like a park or a trail. Parks and open space are an important opportunity for physical activity and also for community gathering. Environmental quality, of course, impacts people's exposure to toxins and other hazards. Climate change is a public health emergency, and it is in Clark County. It had not yet been introduced into comprehensive planning, whereas in other counties there is some more robust look at the impacts of climate change. And economic opportunity is, of course, one of the greatest predictors of overall health in terms of socioeconomic status and its predictive power of life expectancy. And so to encapsulate and to put forth all this information, we developed a document called the Growing Healthier Report. And on the next slide, you can see a bit of an outline of that. So we took these 8 topics on the left, and for each of them, we conducted a literature review. We assessed current conditions, or sort of a baseline for Clark County, and then based on that, we developed a set of policy recommendations on how we could change the existing comprehensive plan to better respond to the need to protect health through our planning efforts. And then I'm going to walk you through a few examples of current conditions and policies. Literature review, I'm assuming most people are familiar with. What you see on this screen is an example of each. So in the literature, we find that unaffordable housing can affect health. The current conditions in Clark County show that 38% of households are living in unaffordable housing. And so one policy option that we can pursue to remedy that is to allow more accessory dwelling units in more areas. And accessory dwelling units are a fancy term for something like a granny flat or a sort of an apartment above the garage or something like that, a dwelling unit that's sort of ancillary to a residence. So on the next slide is an example of how we investigated current conditions in Clark County, and I'm going to apologize that it's so small. I'm an urban planner. I like to make maps, but I'm cursed with working in a county that is portrait-oriented, and so and of course all of my PowerPoints are landscape. Anyway, I hope you can see that the sort of dark orange areas of this map are areas that are within a half-mile walking distance of any food source. And so we estimated the number of people that live within a half mile of any food source, and we further divided that into healthy food sources like grocery stores, supermarkets, farmers markets, and produce grocers, and stores that have fewer healthy options like fast food restaurants and convenience stores. And we found that about 40% of the county lives within a half mile of a fast food restaurant or convenience store, whereas only about 17% live that close to a grocery store or supermarket that has a lot of healthy options. And that was one way we responded to a lot of community interest about the issue of food deserts. And it also demonstrates sort of the relative availability of healthy food to unhealthy food. Measuring access is one of the key things we did for our baseline assessment, and it really reflects the spatial dimensions of differences in Clark County in terms of access to health-promoting resources. On the next slide, you see another example of this where we calculated a walkability index for census block groups in the county. And this reflects kind of the walkability potential of each small neighborhood. And this is useful because it can help us identify problem areas and identify areas that have a high potential for a successful intervention or infrastructure investment. The other thing that this allows us to do is overlay it with other census information, which we did, including many risk factors that we get from census data, like income in terms of socioeconomic status or educational attainment. We also got race and ethnicity and also age. And so by looking at where some of the built environment variables overlap with social determinants of health, we can find areas of high need or high potential. On the next slide, you'll see another example of this, where we measured access to parks. And we tried to especially look at this by some of those risk factors that I mentioned, by age, by race and ethnicity, by socioeconomic status at the neighborhood level, to find areas that were kind of getting hit with a 1-2 punch, where they had poor built environment variables and disadvantages in terms of social determinants. The next slide is an example of how we translated some of that into goals and policies. And we had 3 levels of policy recommendations in our Growing Healthier report. We had goals, policies, and strategies, and that is in order of increasing specificity. One of the tools that we used was a comparison chart, something similar to this, where we had a goal to maximize access to healthy foods, a somewhat more specific policy to remove certain barriers to certain kinds of food retail, and then we compare that to what's in the existing comp plan, and then characterize that as a new change or a modification or just an endorsement of an existing policy. So you can see the second goal really has a lot of policies within the current comprehensive plan, and so we described it as an existing policy. We included that as a policy recommendation, however, to emphasize its impact on health and to raise the profile of that issue and perhaps add a sense of urgency in implementing the policies that are already in the existing comp plan. And the next slide, I'll talk a little bit about lessons learned. If you click one more time, you'll see that on the left here are a handful of planning topics that are really pretty traditional and for the most part are already addressed in most comprehensive plans. The two that come away are food access and climate change, and those really hadn't been addressed through any planning documents in Clark County at this level. And so one of the things that happens with that is we got new sets of stakeholders involved, new issues and terminology and new data that was a challenge both for public health staff and for planning staff, and a new set of advocates. And that was really important when it came time to discussing this at public hearings. On the next slide, you'll see the decision-making structure that we were working within, where we worked together with the community planning department, and then each department had sort of an intermediate level of advising. So we have a Public Health Advisory Council that is appointed by the Board of Health that advises the Board of Health. Similarly, the Community Planning Department has a Planning Commission that is appointed by the Board of County Commissioners that advises the Board of County Commissioners. Then at that top decision-making level, we have the Board of Health, which is the same as our Board of County Commissioners. And that was important because while it was a lot of work and a lot of time to bring it through both branches of that decision-making tree, this had to be approved by the Public Health Advisory Council and by the Planning Commission, then by the Board of Health, and finally the Board of Commissioners. It really brought in a really broad and diverse array of stakeholders who were really enthusiastic about many of the ideas for a variety of reasons. And ultimately, we had a lengthy public hearing with the Board of County Commissioners where there was multiple hours of testimony given on this, almost all of it in favor of advancing the Growing Healthier report as a part of the next comprehensive plan update. And the Board of Commissioners forwarded the Growing Healthier report to the Community Planning Department with direction to fully integrate it into the next comprehensive plan, which was a big success. And I think the next slide, I just wanted to touch on the importance of having that structure when it came time to going to the hearing. This is our county hearing building. The Public Health Advisory Council was probably it's about 20 members, and they represent a lot of different stakeholder groups from the community. We have nurses and doctors, kind of the usual suspects among hospital administrators. We also have law enforcement, emergency responders. We have restaurant and food service represented. We have septic and sewer installers represented. We have education interests represented. And so each of them was able to draw on their own networks and really turn out a lot of people to speak in favor of this. And that was an important takeaway, is that having that structure, while it took a long time, was really helpful in the end. And then I have my contact info on the concluding slide, and I want to leave plenty of time for questions. But you can read the Growing Healthier report at the web address on the screen, and I'm happy to send copies or answer any questions about it.
Great. Thank you so much, Brendan. If you have questions for Brendan, please go ahead and put them into the chat box if you've not already done so. And if any of you have questions remaining from Kirsten's presentation, go ahead and put them in as well, and we'll deal with them as time allows. Betsy, do you have any questions in the chat box yet?
Yes, we do have one. It is,
okay.
At what stage in the comprehensive plan amendment process is Clark County's draft health element currently? If still in the process, what barriers to adoption do you anticipate, such as policymaker concerns or public opposition?
That's a good question. So officially, the next update isn't due until 2016. We're in the very early stages of planning, doing work planning for that effort. Part of the upshot of the commissioner's decision to advance this to the community planning is that now my time is increasingly split between public health and community planning. So that there's a really strong connection there, and that essentially I'm responsible for making sure that the Growing Healthier recommendations get integrated into the comprehensive plan. We're starting that process by opening up the community framework plan, which is sort of the broad level vision statement for the comprehensive plan. And that hasn't been revisited since it was first passed in 1992. So we have a lot of work to do to check in with our community members and make sure we're on the right track, and to address some of the new topics that have come up, not just growing healthier, but we also have other key issues that the community has been rallying around. For example, we have an aging readiness task force, and there are a lot of folks concerned about agricultural preservation. So we have some new topics we need to address. And I think, was there one other part to the question?
Okay. We have another question, which was how much staffing was required to support this effort?
So the staffing that we had was myself and one manager working on this full time. And then we had a team of 4 others who had just a small part of their time available to work on this as well. So we had an epidemiologist who had part of her time working on this, a fellow from the CDC who was with our department for 2 years, spent part of her time on this. We also had our chronic disease prevention manager advising us. So that was roughly the staff commitment.
Okay. The next question is, did you say that there are 20 members of your public health board who rallied to support this initiative?
Yes, the Public Health Advisory Council is about 20 members, and each of them reached out to their networks, and so we had somewhere in the range of 25 to 30 people testifying at the hearing.
Okay. The next question. It is exciting to hear that there is integrated planning beginning to occur. I think about socioeconomic status and that low-income populations in the literature in general experience persistent lack of access to green space. What is the quality of the health outcomes or requirements to equalize access being built into the plan, or is the plan only a guidance document?
Can you read that one more time, just the last part?
What is the quality of the health outcomes or requirements to equalize access being built into the plan, or is the plan only a guidance document?
So
access to green space. Sorry.
Okay. So the plan is in many ways a guidance document, but it is also a policy statement, and there are specific policy recommendations within it that have to be further codified in order to be implemented. So many of the recommendations require sort of a whole nother process of drafting and developing a new ordinance, for example. And so to the extent that the community asks for those to be implemented and acted upon, we'll have a higher quality of outcome, I guess. I hope that answers the question.
Okay, we had another question just come in. The community framework that you referenced in your answer to the first question, is that the agreed upon process or the overarching principles for the planning process? It sounds familiar to the county-wide planning policies that exist in Thurston County.
Yes, so there's quite a bit of overlap between the framework plan and the county-wide planning policies. In the latest iteration or the latest update of the comp plan, the countywide planning policies were basically attached to the framework plan. The framework plan mostly just lays out a vision and states some guiding principles. For example, we want to direct growth to areas that already have existing development. We want to preserve agriculture and green space between cities, those kinds of sort of broad goals.
Do you have any other questions there?
No, John, that is the last question.
Okay, well, I actually had one that I sent, but I'll go ahead and just ask it since I'm online. One is if you could say something, Brendan, about what kind of infrastructure, support, resources, or policies that exist inside Clark County Health Department that makes it possible for you to do this local policy development work. And if we have time, I would ask Kirsten to address that question as well.
Sure. So I think it's pretty unusual for a county health department to have a planner on staff that can focus on built environment issues and navigate the local land use planning process. So that's one advantage that we have. We also have some leadership and management that have really identified built environment initiatives as a way to prevent chronic disease, and they've really championed it both within the department and sort of among the Board of Health and the Public Health Advisory Council.
Okay, that's helpful. Kirsten, could you respond to that question too?
Sure. John, can you just repeat the question again for me?
Sure. Basically, I want to have you help people understand what's required inside the local health jurisdiction that supports or allows you to do local policy work, whether it's infrastructure, resources, leadership, that kind of thing.
So what kind of resources do we have available to support the work?
Yeah, well, yeah. What's required for a local health jurisdiction, or what kind of support have you had internally that's allowed you to do the kind of local policy work that you've been doing?
Sure. So I think there's several things that we had. One is we have flexibility within our program to adapt to some of these issues that come up, and so to have the flexibility to kind of put some things aside so we can focus on new efforts, I think that's really important. We would not have been able to move this policy forward if it wasn't for the support of our higher level leadership in the department. And so, as I mentioned in my presentation, our communications manager was very integral part of our team, and in addition to our division director and just the director of our health department. So each of these individuals put in quite a bit of time and effort into some of the behind-the-scenes work and just the policy process in general. So I think in order to do it, really the support has to be there, and the time and interest has to be there at many different levels of the organization. We're also very fortunate, as I mentioned, to have a pretty strong staff, tobacco staff, in terms of experience, but also in terms of capacity. So we had a few staff working on this issue, and again, it was within a pretty condensed time period. So having that flexibility to do this work in addition to the work that they were already doing was really critical.
Well, that's very helpful. I mean, I think part of the reason I asked that question was because while I'm sure that some of the people that are on the call today are interested in terms of the specific topic of planning or tobacco, I think that what's also useful is to really have an understanding of what's required, both in terms of process and also in terms of resources to carry out any kind of local public health work in a wide variety of areas. And I'm sure that others on the call are or have been involved in local policy development work, and so we want to make sure that there's kind of transferable and generalizable lessons from the work that you both have been doing. So I'm going to close here in a moment, but before I do, I want to just thank both of you so much for the time that it required to put this presentation together and for the excellent work that you're both doing in Clark and Pierce County on behalf of the public health of the state of Washington. And just am very grateful for you, and I'm glad that you left your contact information in there. I want to remind people that the presentation today has been recorded, and you'll be able to access it later. And I'm going to see if I can move forward here and mention that the next webinar, which is occurring on September 12th, is focusing on systemizing communicable disease surveillance and response activities across Washington State. And Betsy, will that be happening at noon as well?
Yes, it will be, and information about that will go out in the next couple of weeks.
Yeah, okay, great. Well, thank you all so much for participating today, and please continue to participate in the webinars and let your colleagues and friends know about them, and we'll see you next time. Thanks so much.